Good morning. You're listening to Masterclasses in Dermatology Saturday Morning Live. I'm Joe Merola.
And I'm Alice Gottlieb. Great to have you with us.
This is your weekend clinical reset. It's fast, it's focused, and it's built for real life.
We'll keep it efficient, practical, and a great start to your morning.
Each of these sessions is designed to give you something you can take straight into practice.
We want to thank our platinum supporters, Eli Lilly and Company, Regeneron Pharmaceuticals, and Sanofi Regeneron for making this program possible.
So wherever you're joining from, we're glad you're here.
Welcome to Masterclasses in Dermatology, Saturday Morning Live. Good morning, everyone, and welcome to Saturday Morning Live. It's 7 a.m. on Saturday, August 8th, and we're so glad you've chosen to start your morning with us. We hope you've been having a wonderful summer, and we truly appreciate you tuning in to spend part of your Saturday with us. We're kicking off today's program with our coffee chat, and we're excited to be joined by a true leader in the field of dermatology, Dr. Andrew Alexis.
Thanks, Alice. And it's Joe Merola here. And I will just give a quick intro to Andrew, who's a good friend and colleague of ours. Dr. Alexis is professor of clinical dermatology at Weill Cornell Medicine and an internationally recognized expert in skin of color dermatology and pigmentary disorders, among many other things. His clinical practice and research have focused on advancing the understanding and treatment of conditions that disproportionately affect patients with skin of color. And he's authored numerous publications and served in leadership roles across many of dermatology's leading organizations. This morning, Dr. Alexis will be discussing hyperpigmentation prevention and treatment, which is an area of growing interest and importance as we continue to improve outcomes for our patients through earlier intervention, individualized treatment strategies, and emerging therapies. So whether you're joining us with a cup of coffee or catching us from clinic, we're delighted you're here. Thank you for spending your Saturday morning with us. Dr. Alexis, welcome to Saturday Morning Live, and let's get started.
So Andrew, how do you incorporate hyperpigmentation prevention into the management of inflammatory skin conditions, and what opportunities exist to intervene before pigmentary changes become persistent?
Well, thank you, Alice. It's an excellent question because this is, one of the big struggles that we have when treating inflammatory dermatologic conditions in darker skin types that are at risk for persistent pigmentary alterations. So there's no better way to control the pigmentary sequelae, the potential pigmentary sequelae, than really effectively treating the underlying inflammatory disorder. So diagnosing it early and initiating the most appropriate, most efficacious therapy early and maintain it longitudinally to control the inflammatory disorder, whether it's atopic dermatitis or psoriasis or acne or others, and controlling that effectively over time generally yields the best outcomes. Now, that's the start. That's the foundation of what we do. But on top of that, we can also add additional measures to treat and prevent hyperpigmentation. Number one, photoprotection. So with photoprotection, we can help prevent the severity of hyperpigmentation as a sequelae of inflammatory dermatoses. Number two, we can advise our patients to avoid certain skincare practices that might inflame the skin further and cause irritation that in turn induces more dyspigmentation. So this becomes a common scenario in something like acne, where patients might feel compelled to do a number of things that might be very exfoliative. They might hear about some treatment that gives them a quick fix and in turn might be somewhat irritating and then induce an irritant dermatitis and cause dyspigmentation. So there's counseling there. And then once the hyperpigmentation is present, other than treating the underlying disorder, this is where we can leverage our various skin lightening compounds, from hydroquinone-based compounds to a whole growing list of non-hydroquinone compounds. So I hope that overview answers your question.
That's great, Andrew. I'm sure we're going to get in the weeds, and I have, yeah, maybe a follow-up to that, and then I'll ask you an additional question. But I find, for some of the, it's a little bit of a tangent, but our sun-sensitive disorders. I mean, I see a reasonable amount of cutaneous lupus, dermatomyositis, et cetera, and I find that patients with skin of color, they're not always used to having used sun protection, sunscreen. Do you counsel differently, or how do you get at that preventative, element differently than in, patients who, might have spent, much of their life spending, putting on sunscreen and hiding in the shadows, as some of us have done.
Yeah, so a very common real world scenario is when we recommend sun protection to a patient who has a darker skin type, they may or may not have had a ton of experience using sunscreens on a regular basis. They might have felt that it's not necessary for their skin type. They might have some previous experiences with sunscreens that were not favorable because of the aesthetics of using some sunscreen agents that leave a white cast. So these are some of the potential barriers to having the patient actually agree to do this. And so how do we overcome those barriers? Well, first off is just explaining the rationale for the sun protection, and explaining that we need to protect against UV and visible light, we might talk about a little bit later, which can in turn worsen the hyperpigmentation, or in the case of the disorders you were talking about, Joe, connective tissue diseases or collagen vascular disorders that are often photosensitive, emphasizing how important it is to protect the skin from the sun to prevent a flare of their underlying condition. And then offering sunscreens that, thankfully, we have newer sunscreen formulations that they just keep getting better and better in terms of their ability to be used across the spectrum of skin types. And so emphasizing that, the sunscreens we have today are more sophisticated than maybe from several years ago. And it's helpful to have samples of various ones that you like to give to the patient to try first and confirm that it goes well on their skin, and then they're more likely to adhere to doing it regularly.
That's great. Sorry, I didn't mean to hijack my actual question for you, but that's fantastic. I think it leads well into this, which is again a broad question, but I'd be interested in your thoughts on patient-specific factors. So, for example, skin type, underlying diagnosis. We touched on this a little bit, say with connective tissue or, lichenoid dermatoses, for example, treatment history or lifestyle. Which of those patient-specific factors most influence your approach to managing the hyperpigmentation? Some of them may be modifiable, some of them not. But curious, your thoughts about individualizing treatment.
Yes. Part of the individualization of the treatment recommendations for sun protection recommendations in the context of hyperpigmentation starts with the diagnosis. If we're talking about melasma, let's say, a condition that we know is very responsive to UV and visible light, this becomes like the very first part of the treatment recommendations, the foundation of what we're describing. And so in that scenario, I tend to be a bit more aggressive with my photoprotection regimen and education. What do I mean by that? I would mean that not just sunscreens, but I would lean into photoprotective behaviors and clothing, broad-brimmed hat and seeking the shade, etc. I might go an extra step and offer visible light protection to a patient with melasma or another disorder that's of hyperpigmentation that is very sensitive to visible light exposure, and recommend a tinted sunscreen instead of a standard sunscreen. I might also recommend oral polypodium leucotomas.
I was going to ask you about that. That's good.
Yeah.
Yeah, yeah.
Yeah, so its potent antioxidant effects have been demonstrated in some studies to be effective at reducing visible light-induced hyperpigmentation and can be used as an adjunct when treating disorders like melasma. So melasma would be a great example of one where you're sort of going all in with every photoprotective strategy we've got.
That's great. Thank you.
I would say I would add the disorders that you mentioned, Joe, that you treat on a regular basis, like lupus and dermatomyositis and other collagen vascular disorders. This is also another scenario where that photoprotection discussion is more extensive. Now, if we're talking about a patient with psoriasis or atopic dermatitis who has post-inflammatory hyperpigmentation or at risk of, then the discussion about photoprotection is still important, but it becomes a little less front and center.
Okay, that makes sense. Thank you very much.
So I'm going to shift gears a little bit. Let's say you have a patient who already does have hyperpigmentation. How do you counsel patients, and what strategies have you found most effective for maintaining adherence during what can be a prolonged treatment course? And so, and the other thing that I'm thinking of, because I've seen patients who overuse hydroquinones, and then they wind up with a worse problem than what they started with. So how do you manage a patient who already has hyperpigmentation?
Yeah, so Alice, you bring up a good point about you mentioned the duration of therapy can be very long when it comes to treating hyperpigmentation, which is absolutely true. So when it comes to the approach with a patient initially being diagnosed and addressing hyperpigmentation, emphasizing to or educating the patient that this is going to take months. This is weeks to months, not days. And we're going to approach this in various stages. And so the very first stage, other than controlling the underlying disorder, which is always primary, in addition to that, in the very first stage, we might lean into hydroquinone containing agents in the first 3 months, 3 to 6 months, depending on the concentration of the hydroquinone. But to your point, Dr. Gottlieb, if one overuses hydroquinone, especially extended long durations of therapy without supervision, we have the dreaded complication of exogenous ochronosis. We can also get irritant contact dermatitis from hydroquinone. We see this more and more as people are compounding higher and higher concentrations, 8%, 12%, and mixing with other ingredients, including retinoids, et cetera. You're increasing risk for irritation, and that can be another limitation of hydroquinone. But I'll generally start with a 4% containing hydroquinone agent, and sometimes to be more aggressive, go up to 6%. I compound up to 6% hydroquinone in the first few months of therapy, so approximately 3 months. After that, I will tell the patient that we're going to transition to non-hydroquinone topicals for longer-term management. And I'll tell them this from the very beginning so they understand that we're going to evolve the treatment as we go along. So what we're starting with today might not be what we're on 6 months from now. And so that gives them a sense of number one, the duration of therapy, and that you're giving thought to different agents for different periods and leveraging something that works faster, like a hydroquinone-based agent in the short term, and using our non-hydroquinone agents for longer term treatment and maintenance.
I wanted to ask you about the triple therapy, one with retinoid, a topical steroid, and hydroquinone. When do you use it? And a little bit, why aren't we concerned about using a topical steroid for 3 months on the face?
Yeah, so there's the classic Kligman-Willis formula that contains hydroquinone, retinoid, and a corticosteroid all in one. And we've had for many years now this FDA-approved fixed combination product that's based on this. It's a modified Kligman-Willis formula, not like the original concentrations and agents, but similar concept. 4% hydroquinone, 0.01% fluocinolone, and tretinoin, 0.05% cream. And this fixed combination is a branded formulation that's been studied and approved for melasma. And few questions arise. Number one, as you said, there's a steroid in there. How could you apply a steroid on the face without concern? So it turns out studies have been done with this triple combination formulation for cohorts of patients that have used it up to 6 consecutive months. Even histological studies were done on these patients. Biopsies were done on some of these patients, and there was an absence of clinical or histologic features of atrophy, and there weren't cases of exogenous ochronosis in this study that was done a number of years ago. Why would that be? We think that the retinoid most likely mitigates the atrophogenic potential of the corticosteroid. However, we do sometimes see some telangiectasias, and that's something we could see clinically from long-term use. So that could be attributable to the corticosteroid. Nowadays, more and more people are. So I talked about that one branded formulation, but many of our colleagues are compounding their own various concentrations of those three categories of hydroquinone, corticosteroid, and retinoid, and even adding other ingredients like niacinamide.
That's great, Andrew. And maybe building on that, because we're sort of sequentially going a little bit down the treatment algorithm. So, I mean, Alice has talked about, we've talked about prevention. We've talked about now some, standard topicals, and maybe even, combination topicals. Let's talk about combination therapy. And what I mean by that is maybe the next layer. So, you're managing now persistent or refractory hyperpigmentation. How do you decide when to add a procedural treatment or an oral therapy to a topical regimen? What either point in the decision, or is it based on the severity, presenting up front, or how do you make those decisions, including background pigment?
Mm-hmm. Yeah, I might bring up to the patient, if it's not overwhelming in the initial consultation, might bring up that we're going to start with topical therapy, sun protection, and these topical prescriptions and non-prescription agents I'm going to recommend. And I'm going to see you back and check on your progress in approximately 3 months. And depending on how you do, we may choose to consider some in-office procedures to get stronger or increase results that above and beyond what we can get with the topical agents. So I might introduce the concept so they can anticipate, but I don't I don't kick things off with procedures. I'll wait for initial therapy with topical therapy and assess how well are they doing on follow-up. How satisfied are they with the progress? Is there persistent dermal pigmentation after a period of time, 3 to 6 months of ongoing topical therapy, and just still have persistent pigmentation that both you and the patient can see? This would be a time to consider in-office procedures such as non-ablative fractional lasers, picosecond lasers, chemical peels, etc.
Are you still breaking out the Woods lamp for the depth of pigment, or?
I am. I still
Okay.
use the old Woods
You haven't
light.
retired your Woods light. That's
I
good.
have not retired. It gets heavy use in my clinic.
That's good.
And it's helpful I find it helpful for the patient physician interaction in that initial consultation, you assess with the Woods light and can maybe offer, okay, you see that it is accentuated, and you tell the patient, I see that a lot of the pigment is superficial or in the upper layers of the skin. This is a great prognosis. I think that you're more likely to respond to our topical therapies. Or conversely, I see that there's a component of a dermal component, and translate that into patient terms, and say that this might require a more multimodal kind of approach where we might need to combine our medications with in-office procedures. So I find it helpful for prognosis and also for the explanation to the patient.
Thank you.
So I'm going to ask a sort of different question, but I actually have an addition to that. So when a patient with facial hyperpigmentation does not respond as expected, what alternative diagnoses or underlying conditions should clinicians consider before escalating treatment? So that's one question. It sounds to me like, control the underlying condition better. But the other thing is what conditions are less likely to respond. I mean, in my experience, lichenoid conditions are less likely to to clear so that you have the same skin, even skin tone than something like atopic dermatitis. And I also find that patients are not happy with partial results. They want their skin to look totally uniform. So um, it's a bit of a loaded question, but what do you do when it doesn't, when your treatments don't work?
Yes, I'll jump right into one of your comments, Alice, that was about you found that lichenoid disorders tend to be more challenging and have persistent pigment. Completely agree. You took the words right out of my mouth. I was going to comment on that. That's been my experience for sure. Among all of our disorders of hyperpigmentation, I think those that are the lichenoid disorders, such as lichen planus or its variants like lichen planus pigmentosus, um, erythema dyschromicum perstans, or this umbrella term that we are now using more and more called ADMH, which stands for acquired dermal macular hyperpigmentation, which includes these disorders, LPP, EDP, pigmented contact dermatitis, and others. So those are among the toughest to treat. I'd also add to that list of the really challenging ones, and it's along the same lines where you have an interface component, and that would be DLE. I threw that in just for Joe's interest, but no, seriously, DLE is the dyspigmentation of that also tends to be more challenging to treat. Now, what was the rest of your question? What I think you asked, well, what other diagnoses do we consider if the hyperpigmentation we're treating is not responding? I think that's a great question. And it does come up quite frequently that a patient who comes in with the chief complaint of a pigmentary disorder, and sometimes we can be fooled too that it is one of the more common pigmentary disorders. But then on closer inspection, we realize that there's more to it than melasma or post-inflammatory hyperpigmentation from a common inflammatory dermatosis. And so I've seen scenarios where the diagnosis is morphia or other forms of scleroderma. And that very frequently presents with dyspigmentation, not just in scleroderma, not just the salt and pepper dyspigmentation that is quite common in that disorder, but also true just hyperpigmented patches. At first, you think they're patches visually, but until you palpate and feel some induration, you realize, oh, these are actually dermal. And so you've got these hyperpigmented dermal plaques, and you're dealing with a lot more than this is not something you're just going to use bleaching agents on, of course. So yeah, taking a pause and thinking about the broader differential diagnosis, including rheumatologic disorders like lupus and systemic sclerosis, but also other multi-system disorders like sarcoidosis also can present with hyper or hypopigmented patches and plaques. So really taking a step back and thinking, do I really have the right diagnosis here?
Thank you, Andrew. So you covered this a little bit. Maybe we'll go to the next level. So with regard to photoprotection in practice, you opened us up and you mentioned, starting to think about visible light photoprotection, for example, tinted sunscreens. And I wonder if you could comment a little bit on specific ingredients we should be counseling our patients on, also about preventing recurrence or worsening of what's already there. We touched on that a little bit, but I'd be interested to hear about your counseling on visible light protection topicals, and then maybe just as a follow-on to the earlier question as well, you mentioned polypodium leucotomas, but what's the run-in look like, or how do you counsel patients? Because it certainly doesn't start working right away. So before sunny season, do you have them start a few months in advance, weeks in advance? What does that look like as well?
Yeah, so when it comes to visible light, maybe approximately 10 years ago or so, we saw some excellent work coming out of Henry Ford primarily, showing that visible light can induce increased pigmentation, particularly in higher skin phototypes. And we also know that tinted formulations containing iron oxide can protect against visible light induced hyperpigmentation. Now, one of the limitations, of course, is that not all patients are comfortable applying tinted sunscreens for cosmetic reasons. Can transfer on clothing as well, and sometimes the color might not match the patient's skin tone. For patients who wear makeup, they can be asked to apply the tinted sunscreen first and then apply their makeup on top and then get a closer color match. That's one strategy. But above and beyond the sunscreens that are applied, the ability to take a pill, such as oral polypodium leucotomas, is advantageous. And in terms of what I counsel patients, I say one capsule twice a day, and they can also be taken at the same time too, but it's two capsules a day. And in terms of the run-in, yeah, I think it's a good strategy to start a couple weeks before any anticipated season or period of time where one might be exposed to the sun, and continue it throughout that period.
Are there any safety concerns and drug interactions when you use this oral agent?
Yeah, I'm not aware of any drug interactions with this supplement, and I don't have any specific safety concerns. It's a very safe or over-the-counter supplement.
And Andrew, I've used it somewhat for, again, for other photosensitive disorders. I think it's a nice little adjunct to antimalarials, for example, for some of our more photosensitive DM or skin lupus. And I think there's some added value, right? People historically for PMLE, I think it's probably useful anyhow, but
Exactly.
and good
It's very useful
tolerability.
for
So,
PMLE.
So I'm going to ask probably a somewhat less interesting question, but still important question. Beyond visible pigment reduction, what clinical or patient-reported outcomes do you consider most meaningful when assessing treatment success? And Dr. Alexis is first author of the Visible study, where they actually used an outcome measure, which I'll let him explain. There are, I think, three different outcome measures that I'm aware of about hyperpigmentation. And so he can describe it. I do think, though, that the most important one is your patient happy? Because if it doesn't really matter if you think it's a good response, but if the patient's not happy with the resultant color, it doesn't matter what you say. I think that we need to be incorporating PROs more in some of these outcome measures. But it's his study, the Visible study, so I'll let him talk about the outcome measure he used there.
Yeah, thank you. No, I couldn't agree with you more that in the routine clinical setting, whether the patient is satisfied and happy with the result is really the key PRO, even though in studies we may use more sophisticated tools, which I will certainly talk about. Um, in terms of the real world setting, just routine clinical setting and assessing if a patient is happy with therapy, a couple different approaches to teasing that out beyond just the open-ended question of how they're doing. You want to get to how much the dyspigmentation is actually affecting them at the end of the day. And if there are scenarios where the patient is it's affecting them professionally and socially, and they have a 30 to 45-minute routine before they get out the door to conceal the areas of hyperpigmentation. Well, clearly you can glean how much of a quality of life impact this is having on them. So being able to tease that out in the conversation with the patient is very helpful. Now, in studies like the Visible study, which was a psoriasis study using the biologic guselkumab for the treatment of psoriasis in patients with skin of color, In addition to our usual psoriasis efficacy measures like PASI and IGA, there were some exploratory endpoints that related to the pigmentary alterations, including a scale that is a patient-reported outcome, which assesses the impact of the skin discoloration on the patient. So it's called the SDIEQ. And the SDI part of that acronym is Skin Discoloration Impact Evaluation Questionnaire. So it queries the patient about how much the pigmentary alteration is affecting them. And it was interesting to see in that study that from baseline to week 16 and beyond, the improvement, from high moderate impact of the discoloration on patients' quality of life to very low impact on their quality of life by week 16 and beyond. And it just goes to show that treating the underlying disorder effectively, psoriasis in this case, in turn results in improvement in the pigmentary aspect as well, even without direct intervention on the pigment.
So, Andrew, this is going to be a little bit more complicated question, but I know you're up to the job. So, thinking about, sort of next generation, I might ask you a little bit to pivot to some of the future directions in oral agents in particular, or other things that you think are emerging. I have to ask about a little bit about oral tranexamic acid. Someone has to say it. I wanted to ask about it. Certainly, as your thoughts on safety efficacy for melasma. Is there any role for other PIH? Because I think it has something to do with vascularity in melasma. Is there a role in other PIH or not? And then other agents you see as the future. We've all heard about oral glutathione. We've heard about other oral agents. What are you reaching for these days? What's the future look like?
Yeah, I'm glad you asked about oral tranexamic acid because it's become such an important tool in our toolbox when managing hyperpigmentation. Melasma is really the main place that we use it, but we now are using it in other disorders of hyperpigmentation too. In terms of how to select patients for it, and we have to remember this is completely off-label. That at higher doses, it's used to stop various bleeding disorders, and so there's some pro-thrombotic potential. But at the doses we use in melasma, the most common dose used around the world is roughly 250 milligrams twice a day. But in the United States, it doesn't come in 250 milligram tablets. We have a 650 milligram tablet. And so what we do is we have patients cut the tablet in half, and they take something that's an approximation of that 250, but a little bit higher. So that's typically what's done. In terms of duration, 3 months is a duration that I'm comfortable with and aligns with the key study that was published in the JAD by Amit Pandya's group back when he was over with you and Alice in Dallas, where it was 3 months and efficacy was achieved versus placebo in 12 weeks. And so 12 weeks is generally a long enough time to see a clinically meaningful result. And also, it's a short enough time that if you're concerned about exposure to this agent that could potentially increase one's risk for thrombotic events, that you're limiting it to a reasonable period of time. And so what I like to do is use those 3 months strategically. If we're talking about someone up in my neck of the woods in the Northeast, with the seasonality, using it in the summer months, where they're most at risk for worsening of their melasma. That's just one example. Or if someone knows that they're going to be traveling somewhere where they're at risk of getting more sun exposure, that might be the 3 months to use. Or conversely, maybe they have something important personal or professional event down the road, and they need to get better as quickly as possible. Well, oral tranexamic acid will get them there together with topicals faster than anything else.
And the other question I had, what if someone has a clot history? Is it a absolute contraindication? Is it a relative contraindication? How are you counseling folks either with known clot risk or higher risk? They smoke, they're on an OCP.
Yeah, for me, I'm pretty conservative in this regard, in that if part of my initial screen is to take a detailed history about personal or family history of thrombotic events. So if they're a smoker, if they're on estrogens, if they've had a history of DVTs or other thrombotic events, well, then they're not a candidate, in my view, at least in my practice. I'm not comfortable prescribing them oral tranexamic acid.
That's super helpful. Oh, sorry, go ahead, Alice.
What about stroke or heart attack? I might feel the same way about
I
that.
would feel the same way.
Yeah, same.
Yes.
And then, sorry, I wanted to make sure we had a chance to hear, as we're wrapping up last few minutes, about anything forward-looking, kind of future directions. And again, we mentioned, I know some folks, glutathione and other things have come up. Anything else you're using or you are hopeful about in the future?
Yes. Well, you mentioned oral glutathione. I have not seen any convincing evidence for its use as an oral agent, since most of it is it's not very bioavailable when it's taken orally. Yeah, I've just not seen oral formulations that I've used in my practice to be convinced that it's helpful for patients. As far as the IV route, that can be problematic, and it's unregulated, and it's available in various settings around the country and around the world, and there have been complications from IV glutathione. So it's not something that I recommend.
That's
So
helpful.
I think we sorely do need another, an alternative oral agent as far as forward looking, another oral agent beyond tranexamic acid to help with more extensive hyperpigmentation. And to that end, just getting back to your previous question about other agents beyond melasma, lichen planus pigmentosus, I've used oral tranexamic acid for brief periods in the order of 3 months, 4 months, to get further improvement in that type of hyperpigmentation. Severe post-inflammatory hyperpigmentation that's extensive, let's say a patient who had a drug eruption and has covered with PIH all over the body, beyond topical therapy, right? So this is someone that I'd consider TXA for as well.
Excellent, excellent. Well, I know we're getting close to the end, so we like to usually give folks any last closing comments, anything we didn't cover that you want folks to know about in this emerging space.
Yeah, thank you. When we were talking about other diagnoses to consider, if a patient is not getting better on, let's say it's a facial, it's hyperpigmented patches involving the face or the head and neck area, and you're treating it as melasma maybe, and it's just not getting better, considering other diagnoses, including, could it be lichen planus pigmentosis? Look at the color. Is it violaceous to gray more than it's brown? Is there involvement of the neck as well? So these would be some helpful clues to differentiate that. But one other thing that we didn't talk about in that context is, what about medications? Oral medications that can induce hyperpigmentation. One that happens a lot is diltiazem and other calcium channel blockers, causing this photodistributed lichenoid disorder with hyperpigmentation. So they're covered with hyperpigmentation on their face, and it has this bluish gray hue. And that's one not to miss. So taking a detailed medication history and looking for potential culprits as well is important, because once you eliminate the medication, then obviously you're going to have a better chance of success.
Awesome, awesome. Well, thank you, Andrew. I'll give it to Alice to close us out. We're very grateful to have you here.
Thank you. Pleasure.
So Dr. Alexis, thank you so very much for joining us this morning and for sharing your expertise. We truly appreciate your time and the practical insights you've provided for our audience and for ourselves. And thank you to everyone who tuned in for today's coffee chat. We hope you found this discussion informative and that you'll be able to apply these pearls in your clinical practices.
And our educational programming is just getting started, so don't go anywhere. In fact, up next, Hope you're not tired of us, because Dr. Gottlieb and myself will be co-presenting an Optimizing Biologic Therapy in Psoriatic Arthritis, Translating Clinical Evidence into Patient-Centered Care session. That's a mouthful, but we're going to be covering a lot about PSA and a lot of emerging therapies, including some really exciting new head-to-head data in that session. This upcoming session is supported by an educational grant from UCB. You won't want to miss our important discussion. And we'll also be back together later this morning for live Q&A, and where we'll answer your questions and continue the conversation. That will include Dr. Alexis, so you can get in any questions you have about hyperpigmentation, photoprotection, or psoriatic arthritis. So thanks again for spending part of your Saturday morning with us. We look forward to seeing you throughout today's program.